Thanks, Simon. Just while the slides are coming up, I moved to Queensland at the beginning of 2010 on one of the Office of Health and Medical Research fellowships. And one of the reasons that I agreed to move here was the support that was put into health and medical research by the government. And by having an official Office of Health and Medical Research, it said something to me. I just hope it survives the current government. So what I'm going to talk about today is evidence-based management of childhood asthma. And I have to say that this was part of an exercise through the Thoracic Society of Australia and New Zealand, and I didn't do all the work. Peter Van Asperen from Sydney did most of it, and he was helped by Craig Mellis, Colin Robertson and myself. And we had previously written management guidelines for the use of inhaled steroids in children, and felt that it was time to update these. So what I'm going to talk about in this presentation is the grade system for clinical guidelines. That's how we determine whether what the strength of evidence and what's the strength of a recommendation that we can make, and particularly based around practice decisions. I am going to say a little bit about what childhood asthma is. I'm not going to say a lot about asthma management guidelines, but I am going to mention them a little bit. And then the main thing is to talk about preventative treatment and treatment of acute asthma exacerbations. So this system called GRADE stands for the Grading of Recommendations, Assessment, Development and Evaluation. And it's specifically for looking at practice guidelines, treatment guidelines, and how we should go about doing things. And it boils down to making recommendations based on the evidence and saying something about the strength of the evidence. So we generally make strong or weak recommendations. These are based on the quality of the evidence, the balance between desirable and undesirable effects, values and preferences, so that if you get two groups of people doing this evaluation in different parts of the world, you may not get the same result. That's important to understand. And most people don't take too much of the cost or resource allocations, but the policymakers certainly do. And that's often taken into account as part of this. So if you've got two treatments which are equally effective, and one's cheaper than the other, the one that's cheaper is going to get the stronger recommendation. And I don't have a major problem with that. So what does a strong recommendation mean? From a patient's point of view, that means that most people would want to have that treatment available to them and they'd want to be prescribed it. From the clinician's point of view, it's understanding that most patients would want that treatment prescribed for them. And from a policymaker's point of view, it means that the recommendations, with strong recommendations, can be translated into policy without anybody getting too upset about it. Whereas a weak recommendation doesn't mean that there's no value in this treatment, but it means that while some people would want it, many people wouldn't. From a practitioner's point of view, it means that you should recognise that there are treatment options. And part of your job is to determine which is the most appropriate option for that particular individual that you are seeing. And from the policymakers, if you implement these things without a lot of work, then you're going to cop some flack. So what about the quality of evidence? High quality evidence means that no matter how much more research is done, it's unlikely to change the estimates of how effective this treatment is. Moderate evidence means that the research says that there's some effect here, but you probably need more research to determine just how effective and what the effect size and the treatment effect size is. Low evidence means that some people think there's an effect here, but you'd actually need a lot more research to determine whether that's a real effect and how important it is. And very low evidence means that nobody's got any idea whether it works or not, and so you need to actually design specific research studies to address that. So that's the framework that later on, when we come to the recommendations that are in this Thoracic Society document, when we say that there's a strong recommendation based on high evidence, you've got some idea of what I mean. So now let's turn to what is asthma. You might think, why would I bother to put up slides like this in an Asthma Foundation Symposium full of asthma educators and asthma-educated pharmacists? I don't make any apology for doing that, because I think that it is really important that we set the ground rules of what we're actually talking about. So, increasingly we understand that asthma is not a single condition. It's a complex, multifactorial problem. It's a syndrome rather than a disease, and what that means from a clinical point of view is that there are many ways you can get to the same apparent clinical endpoint. So we talk about this being phenotypes, and there are different groups of symptoms that produce asthma, and the molecular biologists and cell biologists talk about endotypes, and that means that there are a lot of different inflammatory pathways that end up with the same result. And so it's from this understanding that the realisation comes that there's not going to be a single treatment for asthma, and there's not going to be a single treatment that works for everybody with asthma. And further, asthma arises as a complex interaction between genetic predisposition. We all know asthma runs in families, everybody in the community knows that, and that's an expression of a genetic predisposition. But not everybody in the family gets asthma, and it's because it's the interaction between the genetic predisposition and environmental exposures. And then the third part I've got here is on a developmental background, and what that means is that the same exposure at different times in life can have a different impact. Young children or a developing fetus being exposed to environmental tobacco smoke or a mother smoking has a much greater impact than the same cigarette smoke exposure on an adult. If you're a clinician, you see asthma as a combination of variable clinical symptoms, predominantly wheeze, but some cough. If you're a physiologist, you see asthma as variations in airflow obstruction that you measure with lung function testing. Be normal sometimes, abnormal other times, but variable. If you're an immunologist, you see particularly asthma in early life as variable inflammation, and often in association with allergy. Later on in life, it's chronic inflammation and changes in the structure of the airway wall that's called remodelling that sort of takes the condition past a variable to a more persistent syndrome. If you're a geneticist, you see asthma as a multi-component susceptibility. There is no dominant gene for asthma. There never will be. Asthma is a series of gene-gene interactions and gene-environment interactions that give the susceptibility. So the phenotypic features, the symptoms and the signs that we may see in patients with asthma, you know most of these: cough, wheeze and or cough, low lung function, acute exacerbations in some people, increased airway responsiveness or twitchiness to environmental stimuli, allergen-specific IgE, and evidence of eosinophilic inflammation. But you don't see all of those in the one patient at the same time, and some people have different combinations, and some people never have some of those features. I mentioned the developmental background, and this is important to understanding how we think about asthma and also how we go about managing asthma. And essentially what it means is asthma is different at different ages. There are multiple clinical phenotypes we see in childhood, and I'm not going to go through all of these, but things like early transient wheeze. A lot of babies wheeze but don't have asthma later in life. A lot of kids wheeze when they get viral infections. Some of those will have asthma later in life and some of them won't. Multi-trigger wheeze, where lots of different things set off the asthma. atopic asthma, exercise-induced asthma, and I could put in a whole lot of other phenotypes from adult asthma, but as I'm a paediatrician, this is where my business is. But we know that the major burden from asthma comes from the type of asthma that's going to persist through into adult life. While it's true that a lot of the admissions to hospital, a lot of presentations to the emergency departments for asthma in children are from viral associated wheeze, and these kids aren't going to go on and have persistent asthma. As a community, what really bothers us is the type of asthma that persists into adult life, and this is the type of asthma that people are more likely to die from. This is the type of asthma that causes the chronic morbidity. We know in early life that we can predict with a reasonable degree of accuracy who's most likely to have persistent asthma. Family history. This is the genetic predisposition that I mentioned. Early persistent allergic sensitisation is one of the strongest risk factors for persistent asthma. Kids who have allergy to egg, for example, kids who have eczema, kids who have other allergic symptoms, in conjunction with a family history and asthma symptoms, are more likely to have persistent asthma. The more severe the atopy is, the more likely the child will have persistent asthma. We used to think some years back that people were either allergic or not allergic, but now we know that you have to take into account how allergic they are as when you're looking at risk factors. Wheezing, lower respiratory illnesses in early life is, again, one of the stronger risk factors. This is tricky though, because I've already told you lots of babies wheeze and most of them don't go on to have asthma, so it's a combination of these risk factors. And if you're measuring inflammation, the presence of activated eosinophils in early life is also a major risk factor. So that's enough about what asthma is. And I'm going to move now on to what we should do about treating it, and I'm going to start off with some words about asthma management guidelines. And to some extent, what I'm going to say here is going to challenge a little bit the way you think about asthma management guidelines and the way you actually practice, particularly for the asthma educators. Because basically, asthma management guidelines are a stepwise approach which is based on severity, which means first you have to determine the severity, and I'll say something about that in a moment. But unfortunately, it also means that most of our asthma management guidelines treat asthma as a one-size-fits-all. And I've already told you that that really isn't the case. So the clinicians, and here I don't just mean the doctors, I mean everybody who's involved in the clinical management of people with asthma, need to understand that there is variability within a patient, within different patients, and that there are different treatment options. And sometimes we're not so good at taking that into account when we produce these guidelines. And the bottom line is that if the first option doesn't work, try another one. And again, I don't think that comes across strongly enough in a lot of our guidelines. International guidelines need local adaptation. It's because our environment's different, people are different, and asthma is not a one-size-fits-all management. We need to take the international guidelines and say, how do these apply to our circumstances? They probably apply differently in Queensland than they do in Victoria and Western Australia. But at least we can have, we do want consistency, but we can need to think, okay, is this recommendation right for our community? And what I'm not going to go into, but will be the subject of a whole symposium, is why asthma guidelines don't work. The thing is, they do work. Every clinical trial that's ever been done shows that asthma management guidelines improve outcome. But they also show that they're very poorly taken up. They're poorly taken up by the doctors, they're poorly taken up by the families. You know what I'm talking about. You have the families that you're talking to and you say, have you got a management guideline? Yeah. Where is it? Don't know. They might say, it's on the fridge. Okay, when did you last look at it? Don't know. What happened when you had your asthma attack? Did you use your guideline? Did you follow your plan? No. And this is what I mean. So it's a whole different topic of discussion, which I'm not going to go into any more than that, because there are people in this room who are much better qualified than I am to do this. But I wanted to raise this as an issue. All right, let's turn to some treatment. As I said, first of all, you have to determine the severity. This is now a reasonably consistent way of doing this, although there are changes coming where these types of classification of asthma are not going to be used, and people are going to focus more on how controlled the asthma is. And I think that probably makes it easier for people, and I think Helen's going to be talking about that later in this session, in this day. So basically, you look at daytime symptoms, nighttime symptoms between the exacerbations, how severe the exacerbations, how frequently they are, and for kids or adults who are old enough, you can measure some lung function variability, and use these as a guideline to determining what sort of treatment, where you're going to start. Some basic concepts. The infrequent intermittent asthma. These are about 75% of children with asthma, those who wheeze primarily when they get colds. They don't need and don't benefit from preventive treatment most of the time. The frequent intermittent or mild persistent asthma, these are the kids who have frequent exacerbations or symptoms on most days. They do benefit from preventive treatment, and the guidelines will suggest you either start with a non-steroidal preventer or low-dose inhaled steroids. As the asthma becomes more severe and the symptoms become more persistent, the inhaled corticosteroids are the first line of treatment. In children, although I suspect the same is true in adults, but definitely in children, combination therapy should only be used where the first line treatment fails. And it shouldn't be used at all under the age of 5. And I'll say a little bit more about that as we go on. So what about some of the drugs? Inhaled chromones, these were Intal, nidocrimal sodium. They are still around. There is some evidence that they work in older children, but the practical use of them is pretty much gone. They're much less effective than inhaled steroids for mild asthma. There's practical difficulties with the use. The formulation's not great. If they're in a puffer, they tend to block it up, and you need to take 3 to 4 times a day for it to have actually any effect, and that's just not practical. So for practical purposes, while these drugs are still there, they're not used very much, and they're not recommended much. Leukotriene receptor antagonists. These are effective in frequent intermittent or mild persistent asthma. They are less effective than inhaled steroids for persistent asthma. There's been a number of clinical trials done comparing them, and every one of them the steroids are more effective. They have modest effect at preventing the need for oral steroids in preschoolers when they're used intermittently, and I'll say a little bit more about that in a minute. They may prevent a phenomenon which is very common in the United States and Europe, but less common here, and that's the return to school exacerbations. In the US, there's major epidemics of asthma exacerbations every September when the kids go back to school. And taking these drugs before that there has been shown to be effective at preventing that. They are very good at preventing exercise-induced asthma, and there is no evidence that you get tolerance to the effect of exercise prevention with these drugs where there is with some of the others. And they have a good safety profile. The inhaled corticosteroids, as I said, they're the first line preventer for persistent asthma. I'll say a little bit more about the dose in a minute, but the HFA fluticasone, half the dose is equivalent to the CFC beclomethasone because of the way it's formulated. Once daily ciclesinide is effective. There are studies to show that it works. And the dose that you receive in all inhaled steroids depends on the delivery device. And for young children, I'll say something about that a little bit later. There is no effect of inhaled steroids with intermittent viral wheeze. They do not prevent exacerbations with viral infections in young children. They do, inhaled steroids in someone with persistent asthma does improve exercise capacity, but it does it primarily by improving the asthma control. They're not really a treatment for exercise-induced asthma in the absence of poor control. I do have to say, though, in most children, particularly young children, where you're getting exercise-induced symptoms, it's because their underlying asthma is not controlled. That's not necessarily true in teenagers or young adults, where they exercise enough to actually induce asthma in the absence of poor control. So the doses of inhaled steroids, what are considered the initial doses for budesonide, about 400 micrograms, for fluticasone or HFA, beclomethasone, 200 to 250, or ciclesonide, 160. They're the initial starting doses which are recommended. These are micrograms per day, given twice a day except for ciclesonide, which is once a day. High dose is considered, depending on the age range, to be an increase in the dose. And I'll say a little bit more about the high dose steroids in a minute. Combination therapy, as I said, it shouldn't be used under the age of 5. That's because there are no data to show that it works. There's no data to show that it doesn't work, there's just a total lack of data. And so in the absence of data, we do not recommend, as a standard part of the treatment, using combination therapy. However, in Australia, about 40% of kids are started on combination therapy as first-line treatment, which is against all of our guidelines. There are not that many data either in kids over the age of 5. There's reasonable data in teenagers as part of adult studies, but there's not a lot of data in kids about combination therapy anywhere. What data exists shows that they are effective for persistent asthma that's not controlled by low-dose steroids. They shouldn't be used as first-line treatment, and there's very little evidence, positive or negative, for the SMART treatment strategy that's often used in adults in children. And the bottom line message here is combination therapy is vastly overused in childhood asthma. I want to tell you about this particular study out of the United States, out of the University of Wisconsin, known as the Badger Study, and I'm told it's the Badger Study because that's the name of the football team from the University of Wisconsin. This was a very clever study. They took a whole lot of kids, I've forgotten how many, but it was a substantial number, who were not controlled on 100 micrograms per day of fluticasone. They were then randomised to a 3-way crossover, so every kid got each treatment in this study. For 16 weeks of add-on therapy, they either had salmeterol added to the fluticasone, they either had a leukotriene receptor antagonist added, or they had the dose of fluticasone increased from 100 to 250. And the primary outcome of this study was to see whether they could gain asthma control. And they were really surprised that 95% of the kids in this study gained good control of their asthma on one or more of the treatments. If they looked overall, the combination of fluticasone and long-acting beta agonists, so fluticasone and salmeterol, was the most likely to achieve control. But there were kids who the best option was leukotriene receptor antagonists, and the kids who were the best option was increasing the dose of fluticasone. And they were not able to predict, apart from African Americans, who we don't treat very many of those in this country, they do badly on leukotriene receptor antagonists without adequate dose of steroids. So apart from that subgroup, there was no way that they could predict which was going to be the best add-on therapy for an individual child. And so this just highlights the importance of this one-size-does-not-fit-all concept. So that if you don't achieve control by adding a long-acting beta agonist, take it away and try something different. And that's the message from this study, and it's a very important one. All right, let's turn now to some of the evidence for using inhaled steroids as preventers. we consider that inhaled corticosteroids, I'm sorry this slide's it's going to be a bit hard to read from the back, but all of this is available on the Thoracic Society website. So inhaled corticosteroids for first-line preventers for moderate to severe asthma is a strong recommendation based on high-quality evidence. Using non-steroidal as first-line treatment for milder asthma and moving to inhaled steroids if there's no response over 2 to 4 weeks is also based on strong evidence and is considered to be of high quality. Titrating the dose against severity, that means once you've achieved control, dropping the dose back, or if you haven't achieved control, increasing the dose till you do and then dropping it back to achieve the lowest dose that's possible to maintain control is also a strong recommendation based on high quality evidence. A little more controversial, specialist referral for children who need high doses of inhaled steroids. We think that's a very strong recommendation, but unfortunately the evidence isn't actually there for that, primarily because the studies haven't been done and they'd be impossible to do. There is, just looking at the side effects, there is a strong evidence a strong recommendation that dose-dependent systemic activity for all types of steroids, including inhaled steroids. We see short-term growth suppression